Welcome everyone to the first CIS webinar for the year 2016. I am Shan Chandrakasan from Emory University, Atlanta. I'll be co-hosting this webinar with David Hagen from University of Washington and Joyce Hugh from University of Columbia. Before we proceed, I would like to sincerely thank Kate Sullivan and this Clinical Immunology Society for coming up with this amazing platform for many early career immunologists to interact real time with some really interesting real-time cases. So we will take maybe a minute or two before we proceed to the next presentation, but I would like to point out to all the audience here the chat option that is available. So the most of this discussion is done real time. So I would really encourage you to just type in and say where you're from, maybe an interesting trivia about the place where you're from, so that we get to know you better and we will be interacting real time. So, and just to remind you, this CIS webinar is also co-sponsored by USIDNet and Latin American Society of Immune Deficiency. And I see people from Peru, people from Italy. Wow. So I've been on this from the first webinar, and it's been so impressive how this platform has really taken up. So, and one last pitch would be for all the early career immunologists and fellows in training. So there is an awesome resource. If you get to be a member of Clinical Immunology Society, you do get access to previous Clinical Immunology Society annual meeting presentations and multiple other benefits. So for trainees, the membership is really free, and for the early career immunologists, it's highly subsidized. So I would highly recommend people to consider becoming a member of CIS and support our initiative here. So Joyce, shall we start?
All right. Yes, we should. All right. So, as has been for our past case conferences, we will start our webinar with a brief literature review of recent highlights from the JOCI. So the three articles I'm going to present today. The first article is magnetic or MRI imaging. May be a valuable radiation-free technique for lung pathologies in patients with primary immunodeficiency. So as you all know, that we generally use CAT scans to evaluate for pulmonary complications in our PID patients. However, there are definitely concerns in some of our patients who have radiosensitivity. For example, our CVID patients and ataxia telangiectasia patients who might be at risk for possible malignancy due to the radiation, and also as well as general concerns for radiation exposure. So some prior studies have shown some concordance in terms between the CAT scans and the MRIs for picking up moderate to severe lung disease, but some differences between the CAT scan and MRIs for picking up milder pulmonary disease. Also, it's been shown that perhaps the MRI might be better at detecting the parenchymal abnormalities, whereas the CTs may be better at picking up bronchiectasis. So the authors in this study wanted to compare MRI imaging versus CAT scan imaging for the diagnosis and follow-up of lung disease in PID patients. So they included 23 subjects, and as you can see here, the variety of subjects that they included, most of them were CVID patients, but a smattering of hyper IgE, IgA deficiency, and one CD19 deficiency. As you can see, the ages varied from 20 to 60, more or less, about 50-50 between the females and males. Everyone had both an MRI and a CAT scan, and about 66% did have abnormalities seen on the lung CAT scan. They used the BALA scoring system, which is like a validated CAT scan scoring system, to evaluate pulmonary abnormalities in 9 different areas, and as well as compared the detection for pulmonary nodules. So in terms of radiographic findings in the MRI scans versus the CAT scans, they found in most of the PID patients that bronchiectasis was the most common finding. However, the MRI scans seem to detect less bronchiectasis extension and like bronchial generation versus the CAT scans. However, the CAT scans identified more peripheral abnormalities versus the MRIs. However, in terms of identifying consolidation, bullae, mucus plugging, bronchial wall thickening, just severity of bronchiectasis according to the scoring system, and the nodules, the MRIs and the CTs seem to have a similar identification rate. So the authors of this paper concluded that the MRIs could be a possible option for following lung disease in PID patients, especially those who have more than moderate to severe disease, and perhaps that could help reduce radiation risk. So the next paper I want to review quickly is a multiplex kindred with Hennekam syndrome due to homozygosity for a CCBE1 mutation that does not prevent protein expression. So Hennekam syndrome, it's an autosomal recessive syndrome that includes the features of intestinal lymphangiectasia as well as lymphedema. These patients also may have variable features of developmental delay, dysmorphic facies, thyroid issues, skeletal, cardiac, and renal abnormalities. Basically, CCBE1 encodes an extracellular matrix protein that's involved in lymphangiogenesis. And it's of the 45 reported patients with the Hennekam syndrome, only about 22 have been found to have mutations to be associated with the syndrome. However, the majority have unknown mutations, and the pathogenesis of the CCBE1 mutation is unknown. So the authors in this paper studied a pair of siblings with the Hennekam syndrome who they come from a family with consanguineous Turkish parents. They have the features, as you can see here, including lymphedema, chylosociety, hernias, low protein, hypothyroidism, as well as hypogammaglobulinemia, but normal T lymphocyte subsets. These two siblings were homozygous for this C174Y mutation, which was previously reported in other kindreds, and it's in the calcium binding domain. And in this family, it was identified by home exome sequencing and confirmed by Sanger. In these two patients in the study, they performed some in vivo and ex vivo studies. An interesting one, they showed that there's actually an increased intracellular expression of the mutant CCBE1 versus the wild-type protein in the transfected HEK cells who had overexpressed plasmids. However, the mRNA levels between the wild-type and the mutant plasmids in the transfected cells were basically the same. The wild-type and the mutant CCBE1 proteins seem to be localized primarily in the cytoplasm when they looked at the cells on microscopy. And when they looked at the supernatants of these transfected cells, they found that there seemed to be relatively higher levels of the mutant protein secreted into the supernatant versus the wild-type protein. Additionally, when they looked at immunohistochemistry, they found that the patients, they took duodenal samples from the patients, and they found that the patients had decreased staining for the anti-CCBE1 as well as the anti-D240 antibody. So they proposed that perhaps rather than that the CCBE1 mutation, instead of preventing protein expression, it actually perhaps leads to normal or even slightly increased intracellular expression and secretion of this protein. And perhaps one of the reasons why there's abnormal phenotype is that perhaps there may be, the authors propose perhaps there may be some abnormal folding, or perhaps maybe faster degradation of these proteins when they get secreted into the supernatant, or maybe some impaired interaction between these proteins and other regulatory proteins, so that way it impairs the lymphangiogenesis. They also propose that perhaps with this particular syndrome, because not everyone has the same spectrum of phenotypes, perhaps there may be a variable penetrance of certain clinical features versus perhaps maybe some variable expression due to perhaps some genetic modifications or some environmental interactions with the genes as possible reasons why these patients seem to have a heterogeneous phenotype. And the last paper I wanted to review really quickly is it's actually an analysis, so it's of 161 children with PID in Mexico. Basically, it's a nice chart review of PID patients that were seen at the National Institute of Pediatrics in Mexico City. So it's another nice registry paper. So it's a nice, good reference for us in terms of, I know, like, we're, Kate's big thing for registries here. So what they did in this paper is they looked at actually PID patients over basically essentially 2 decades, but they analyzed them in 2 groups, so basically from 1991 to 2001 and in 2002 to 2012. They ultimately included 161 patients. 68%, so majority were male, or 2 to 1 predominance male versus female. And at the time of the analysis, about 86% were alive. They noted there's definitely some consanguinity in some of their patients, as well as positive family history in about a quarter of their patients. Interestingly, or not so interestingly, about the majority of their patients, about 80%, were diagnosed after 2001. And that was, and they conclude probably is due to the fact that the FUMENI, it's a foundation for PID patients in Mexico, as well as a PID advocacy group and a support group in Mexico were established in that particular year. So perhaps like increased awareness of PIDs at that time. Greater than half of the patients came from the Central Valley in these particular states, the Hidalgo, Michoacan, Querétaro, and Quintana Roo states. Authors propose that particularly in the Hidalgo and Michoacan states, there's definitely higher rates of consanguinity, so perhaps that's why we're seeing more PID patients there. The median age at the initial symptoms was around 8.5 months, and the median age at first infection was about a year. The median age at diagnosis, however, was about 5 years, so like 61 months, about 5 years, with a median delay in diagnosis of 22 months, so quite a delay. In terms of the spectrum of PIDs that were seen at this particular center, about a quarter antibody defects, which was the majority, or at least a large number of phagocytic defects, as well as a number of other well-defined syndromes. And in terms of the variety, as listed here, XLA, CGD, ataxia telangiectasia, CVID, SCID, and WAS accounted for the majority of their cases. Actually, they did make an interesting point, though. Here in the U.S., we see a lot of people with antibody defects, especially specific IgA deficiency, whereas they actually note that they did not see a lot of patients with specific antibody deficiency. And as you can see here, even though 29.8% of their patients had antibody defects, the number of percentage is not quite as high as what we see in the North America. So that's definitely a difference in terms of what we see here versus down in Mexico. Let's see, in terms of complications, about 86.3% had infections, as to be expected. Respiratory infections were the most common, and gram-negative bacteria were identified in about half of the or more than half of the patients. However, as we see in other registries, several patients also had coexisting atopic conditions, autoimmunity, as well as malignancies. Many of these patients received treatments just as we do in the North America registry, including antibiotics, IVIG, interferon gamma, GCSF, steroids, immunosuppressants, biologics. They also note that they actually treat some of their patients with the leukocyte dialysate, which is what we don't really typically do up here in North America. So that's definitely something that's interesting that they do in Mexico to treat their patients. And about almost 10% got stem cell transplants. In terms of the survival, the overall mean age at death was about 81.3 months, which I think is around 8 to 9 years, with infection and bleeding as the most common causes. And interestingly, when they look at the Kaplan-Meier survival curves, before and after 2001. So remember, they looked at the first 10 years versus the second 10 years, and they actually, show no difference in survival rates before or in the first 10 years versus those patients that were identified in the second 10 years. And however, with both before 2001 and after 2001. However, the drop off was quite steep after 10 years for both groups. So anyway, this concludes the literature review. Any comments from Sal?
No, thanks, Joyce. This is really interesting.
Okay,
great. It's always heartening to see this registry data from developing countries and countries throughout the world, just to appreciate the diversity and profile of immune deficiency and the management profile in different part of the country or the world. So thanks again. So the next case is a very interesting case to be presented by David Hagen, and the senior mentor for this case would be Dr. Hans Ochs. We all know Dr. Ochs. He is a solid leader in the immune deficiency world, so we are looking forward to this presentation and also his comments on this case. David.
Thank you, Sean. So I would like to present a case of familial autoimmunity. And it's kind of a retrospective case because by the time we saw this patient, they were already adult patients. So it was going back and dig through their chart and see and get information on how things have developed. So the first patient is now 34-year-old female, and she has quite an impressive history of autoimmunity. So she started very early, at around the age of 12 months, first with arthritis. Notes describe involvement of mostly small joints in her hands at first, but then after several years, it progressed to involve larger joints, mostly knees and ankles as well. Around the age of 12, she developed dry mouth and dry eyes. Antibody screen was positive for ANA, but was negative for anti-SSA and SSB. So she was given the title of overlap syndrome. I guess we need to give them some definition so it will be easier for us to treat these patients. In her early teen years, she went on and developed autoimmune hemolytic anemia and autoimmune thrombocytopenia, and she required frequent blood transfusions. And that's something that she still has to do to deal with even today because she has iron overload due to this transfusion. Around the age of 16, she started suffering from chronic diarrhea, and that was persistent severe diarrhea with weight loss. She had a colonoscopy, and the biopsy showed lymphocytic infiltrates. I wasn't able to find more data about the biopsy, but just one of the notes specified lymphocytic infiltrates. She was walked up for celiac disease, and IgA deficiency was found. So now we have a patient with overlap syndrome and IgA deficiency. 10 years later, around the age of 25, she started developing dyspnea and respiratory symptoms, and chest imaging shows lung disease, interstitial lung disease. She underwent bronchoscopy mostly to rule out infectious cause, and that was basically ruled out, but again, they didn't see any biopsy which specified what was exactly in her lungs. Except for the autoimmune hemolytic anemia and thrombocytopenia, at one point she also developed neutropenia, but that was around some other infection. So they believe that the neutropenia and also bone marrow biopsy that she had at the time, which showed hypocellular bone marrow, was secondary to a systemic infection. Other than that, she did not have significant history of infections. So one episode of neutropenia with fever and some kind of infection, but no other infections. Over the years, she was treated basically with everything. So they tried azathioprine, methotrexate, and you can see the list. She also received several rounds of rituximab around the age of 22. But most of the time, she was kept on high dose of prednisone. The maximum dose was 120 milligrams a day, and that was something she was taking for more than 10 years. She's a small lady. Her weight is 53 kilograms, so it's pretty high dose of more than 2 milligrams per kilogram. So she first came to our attention by the age of 27. So that's just to show you 5 years after she received her rituximab treatment, and that was the first time that she had an immunological evaluation. CBC was overall normal when we saw her, so normal platelet count and normal hematocrit. Lymphocyte subsets showed maybe somewhat reduced lymphocyte count with total CD3 of 622, low CD8 of 112, and no B cells, so CD19 of 0, and that was 5 years after she received the rituximab. Further evaluation showed that she had very low IgG level of 109, normal to mildly elevated IgM, normal IgA, but in addition to this low IgG level, or maybe in accordance with that, she didn't respond to pneumococcal vaccine challenge. So basically 0 out of 23 serotype were above 1.3, no response. When we evaluate the cellular compartment, so she had normal response to CD3 and PHA. Cells were proliferating as expected. Additional workup, kind of the usual one, she had normal oxidative burst. She had high percent of double negative T cells, but that was out of the total CD3, so these were not alpha beta TCR positive cells. And at that time we also sequenced A1, and that was normal. The patient was started on IVIG and was followed yearly in our clinic. So the second patient, that's her sister, younger sister. She's 32 years old now, and she has somewhat different clinical history. So she was a healthy child, totally healthy child with no issues with autoimmunity, no recurrent infection, basically normal. And the first time she presented was around the age of 23. At that time, she presented with neurological symptoms, started with numbness involving the lower extremities, and then developed later into muscle weakness. She had an MR study which showed abnormal signal in the lower spinal cord, T5 and below. LP lumbar puncture showed pleocytosis with more than 100 mononuclear cells. And she was diagnosed with transverse myelitis. She was treated with steroid with improvement. Over the years, she developed other neurological symptoms, ocular symptoms with diplopia, and repeated MR showed now involvement, CNS involvement with white matter lesions in her brain. Repeated LP showed elevated CSF IgG index, which could suggest MS, and she indeed was given the diagnosis of atypical MS, or neuromyelitis optica, or systemic CNS vasculitis. So basically, we don't know what you have, but you have something in the CNS, so we'll call it MS. She was treated with steroids and responded partially to steroid treatment. Around the same age, as part of her evaluations, she also had chest imaging, and there was an incidental finding of multiple lung nodules. The patient at that time was not very symptomatic. She had an open lung biopsy which showed nodular lymphoid neoplasia without granulomas, cells stained positive to CD3. She had some plasma cells and very few B cells. The biopsy also showed some background story from fibrosis. So because of the fibrosis, IgG4-related disease was suspected, especially with the response to steroid before. So I think that somebody connected fibrosis with steroid response, and IgG4 was brought up. At the age of 26, she's being followed. Repeated chest CT shows progression of her lung disease. At one point, she also developed arthritis with some knee and small joint symptoms that wasn't very severe. But over the years, she suffered gradual progression of her neurological symptoms with seizures, and at the same time, her lung disease also got worse. She was treated with IVIG and rituximab, but that didn't really change the course of her disease. When she was 25, that was the same time when we saw her sister, so she was also referred to our clinic, and initial immunologic evaluation was, we started with initial evaluation. So she had normal CBC, she doesn't have any history of cytopenias, and her lymphocyte subset is also normal with normal CD3, CD4, CD8, and she does have CD19 cells, despite the fact that actually she was treated with rituximab later, so we can't say much about it, but she did have B cells before treatment. Further evaluation showed low IgG at 490 with normal IgM and IgE. She also had protective antibody titers against tetanus and also varicella, another thing that we tested. But again, no protective titers against pneumococci and no response to a vaccine challenge. The cellular component, so normal response to CD3 and PHA. She also had normal oxidative burst, normal CH50. By that time, we also got B cell phenotyping, and her B cell phenotyping was abnormal. So she had mild B-cell lymphopenia, and you saw the count of 88 per microliter. But when we usually check the maturation of the B cells, so you can see in the panel below, we stain the cell for CD38 to CD24, and we know that they are going through several steps of maturation. They start on the right upper right side as CD38 positive, CD24, and these are naive cells, and you can see that there is nothing there, so she didn't have any naive immature B cells. She does have the upper component, the mature B cells, which are on the bottom part of the panel, and the switch memory B cells on the upper left.
So, David,
yes.
Can we hold the slide and ask for audience inputs? So we have two family member with multi-organ autoimmunity and with a B cell panel that would suggest you of B lymphopenia and hypogam. Could be labeled CVID, but let's see what the audience have in terms of inputs, questions, or comments. Audience, please feel free to use the chat and let us know your thoughts.
Okay.
So the question, one of them, for the first case, do we have a pre-rituximab B cell panel or B cell count?
We don't have a pre-rituximab because we saw her after 5 years after she received her first rituximab treatment. So, but we know that the B cell count, the 0 B cells, are 5 years after the rituximab. So we don't know what happened before.
Okay. So do we have a Treg function or numbers because of multiple autoimmunity that's been ongoing?
We don't have it, and we usually don't check it routinely in female patients, just because it's an X-linked disease. Check it later on. Maybe I should go to the next slide. Just briefly go over the family history. So as far as we're concerned with the family history, the father has history of ITP and Hashimoto's, and otherwise he's doing okay. So you can see now the pedigree of the family tree, and that's how it looks. We have we consider him affected, and 2 affected daughters, but that's all the affected people in the family that we know about. So we did check the Tregs on the father, and he had normal percent of Tregs. I think it was in the range of 3%, normal FOXP3 expression, normal CD25 expression, so it looked totally normal. Shall I continue with the next, just to summarize the case? So we have a case of familial autoimmunity with some common features shared by the 2 siblings. They both have lung disease and antibody deficiency, but each of them also have unique features. So one of them had severe arthritis and overlap syndrome and GI symptoms, and the other had CNS involvement, but without any of the others. And we have another affected family member who is basically asymptomatic. So I'll be glad to hear any thoughts or suggestions.
So any differential diagnosis offered by the audience? The last 4 or 5 years, we have increasing number of genetic etiology identified for this multiple autoimmune immune dysregulation disorders, right? So I see some CTLA4, STAT3 gain of function.
Yeah. So I think when we first saw them, none of these diseases were known. So we didn't look for these.
So I was also curious to know if we have a CD45RO on your patient, just to see if what is the naive versus memory population on the T cell panel.
We had it on one of the patients, on the second patient with the CNS involvement. But she had relatively normal T cell phenotyping, so she had somewhat abnormal ratio of CD4 to CD8, and you can see that the CD8 was low, so high number of compared to CD8s. And it was mostly naive, so we didn't see a lot of cells which were pushed all the way to maturation, not a lot of tumor cells in the TCA, or not a big population of effector memory cells. mostly naive. And I don't know if that reflects actually what happens in her cells, or just because she received a lot of immune suppressive drugs because of her CNS involvement.
Okay. I see a lot of response for CTLA4 haploinsufficiency. So I was just wondering what in the clinical manifestation that is more differentiated from other immune dysregulations like LRBA and TIC3CD that the audience thinks would make it more likely to be CTLA4 versus other differentials.
Yep, I think the inheritance pattern of autosomal dominant disease probably suggests that. So we had that family in mind for a long time, and what we usually do, we have these families, and when you review the literature, something comes up, and obviously you test for that. So the combination of CVID, lung disease, and CNS kind of suggested let's check CTLA4, and that's actually what we did. And what we found is a mutation in CTLA4. Now I wanted to show something about this CTLA4 because at first we were very glad that we know what the answer is. So this family has CTLA4 mutation, and we again went back and checked the two siblings and the father. They all had the exact same mutation. But there's something which made me feel somewhat uncomfortable about this mutation, is that we found a mutation in a splice site. And if I can say a few words about splicing, so first, when the mRNA is being transcribed and we get the exon and the intron and the exon, at both sides of each exon we have two splice sites, and one of them is considered the donor splice site, and that you can see it on the left side of the screen, and the other one is the acceptor splice site on the right side of the screen. They are relatively conserved, so the donor splice site almost always starts with has an AG, but the donor splice site on the left is not that conserved. So you get GT at the beginning, and then you can get either AG and then AGT. But on this slide, you can see the percent of the nucleotide that you can find in that position. So at the end of exon 3, at position +6, you can find T only at 47% of the cases, and that's exactly where we found our mutation. So it makes you wonder if it means anything or if just an incidental finding. So what we had to do is continue investigating that case, and we decided that we need to extract RNA, extract the cDNA, and sequence that to see what we actually get. And that's what we did. So on the bottom right, you can see a gel image. I can't show them now. A gel image, and you can see the ladder on the left, and then the healthy control on the middle, and the patient cDNA on the right side. And you can see that the healthy control is one band, and that's the exact right size of the CTLA4 cDNA. The patient, on the other hand, has two bands. One of them the same size, but the other one is smaller size. So we have two different bands. We extracted these bands and we sequenced them, and what we found, you can see it on the slide. So the healthy control and also the normal band size of the patient showed, when we sequenced it, we found actually the whole 4 exon. And here in blue you can see exon 2, in green you can see exon 3, and in red you can see exon 4. So on the top side of this figure, the healthy control, you can see you can find in the mRNA the all 3 exon. But then when you sequence the smaller band, you can see that the blue connect directly to the red, which means that exon 2 is being spliced directly into exon 4, and exon 3 is being skipped. And exon 3 is an important part of CTLA4 because that's exactly the transmembrane domain. So basically what we get from that is that the patient has haploinsufficiency because he has one normal copy which with the product of normal length CTLA4, and then we have the second allele which give rise to partial protein without the transmembrane domain. Any suggestion how to treat these patients before? I think we are over time for my case. So I see that question on the left. So this variant was not described. We couldn't find it in any database. It's not in the exact browser or EVS or exome variant server. So that was never described before.
I just want this case to bring up to discussion with Dr. Hans Hawks to see, like there are a lot of, as you said, there are a lot of other immune dysregulation disorders like LRBA, PIK3CD, NF-kappa B2, so that can present with multiple autoimmune manifestations. So in terms of diagnostic workup, how do you go about working up this patient, and do you plan on doing a next-gen multiple panels, or go one at a time, or even in terms of flow, there are not very great flow studies for these defects, right? So I would like to hear even the audience response and also what Dr. Hans Hawks has got to say.
Well, as David mentioned, this phenotype in these three patients with various expression of the phenotype was very suspect to be CTLA4 haploinsufficiency. And so I think it was the right step to first have a stab at CTLA4. And in fact, it was bingo. But there is another approach, and that would be whole exome sequencing. And I think most whole exome sequencing would recognize the mutation, because whole exome sequencing takes part of the exon-intron sequences. And I'm not sure how far in, but I think everybody who knows these splice site problems would do at least 6 to 10 nucleotides in the introns. So I think if you have, I think it's good to think first and take a stab at one, and if that particular gene is not positive, identified as causing the disease, then you probably have to do whole exome sequencing. But here you can see that it was easier and cheaper to go for the most obvious mutation, and that was CTLA4.
And just to amplify what Hans said, when you see the combination of neurologic involvement plus lung involvement, you should really think CTLA4 or LRBA. And in this kindred, LRBA is autosomal recessive and CTLA4 is autosomal dominant. So of the two, CTLA4 was really the one that fits. So this isn't just a case of pleomorphic autoimmune disease. That combination of neurologic involvement plus lung should really trigger CTLA4 for you.
And it's very interesting that you see those different phenotypes, the father being very mild. And I think when you have a dominant disease, that can happen. Maybe if we would have done these experiments by looking at the message, maybe the father had a stronger band, a normal band. If you look at these two double bands, they are equal in the patient. But maybe if we would have done in the father, maybe there is a greater expression of the normal allele than the abnormal. This is hypothesis, but we still have no explanation why there is this incredible difference in the clinical expression of this haploinsufficiency.
A quick word on the management of these patients, David?
We'll do it quick. I mean, if anybody wants, you can email me and we can tell you about the protocol. But we transplanted both siblings. Patient 1 is now 4 years post much unrelated donor transplant, and patient 2 is 120 days post transplant. They're both doing much better. So yeah, I think we think that with severe disease, stem cell transplant is probably a good option.
Did in terms of medical management prior to transplant, was sirolimus or hydroxychloroquine or abatacept tried on this patient?
I think at time points they were on everything, including Tisabri and Tisabri for MS and different immune modulators. They tried a lot of things, and that was discontinued either because of side effects or lack of effectiveness. So we ended up, and I think the patient themselves, the first patient had this transplant, and then her sister saw that she was doing much better. She herself kind of asked for that because she wanted to be off treatment.
Okay, thank you so much, David. Thank you, Dr. Hans Hawks. Let's wind up the first case and go to the second case. It's another interesting case being presented by Lucila Adriana from Lima, Peru. And the senior mentor for this case would be Juan Carlos from Lima, Peru. We all know him by being a very active member of early career immunologist, and he has recently come up with a book with a more simplified cartoonish version of immunology for most of the maybe for medical students and also for the residents. It would be an interesting buy. It's on Amazon. Go ahead with the case. Thank you.
Hi, good night, everybody. Thank you, CIS, for this amazing opportunity. I'm having some troubles because I'm not seeing my presentation. I don't know if it's the connection.
Muted.
We can pass the slide if you want. We can change.
We can see your presentation.
Okay.
Gisela, you can't have the computer and the phone on at the same time. It'll echo.
Okay.
Well, Gisela is trying to phone in again to get a better connection. Let's just talk a little bit about the previous case. So they elected to do transplant. There's some data that demonstrates that the median life expectancy from the time that symptoms first appear in CTLA4 deficiency until a patient dies is only 13 to 15 years. Now, we don't know if there's a better treatment that might prolong that, but certainly it has a worse prognosis than probably we imagine.
I think one of the problems is to decide when you need to transplant them, especially if they're not that symptomatic when they present.
Well, I noticed you didn't transplant the father, and it would be hard to justify for thyroid disease, but you wonder what will happen to him down the road.
Hi, I'm back. Thank you very much. Sorry for the inconvenience. I suppose it was the line, so I'm ready to present if you are.
Yeah, go ahead.
Okay, is the audio okay? Could you listen me fine?
Yeah.
Okay, well, good night. We are going to present a really difficult case, a mystery case for us. We have already presented it in the CIS list, and we still don't have answers, so we are really looking forward for this opportunity. This is a case in the hospital I'm doing my fellowship, Hospital Nacional Edgardo Rebagliati Martins in Lima, Peru. So let's start with the case. Well, this patient was presented to us on May 2014 at the age of 10-year-old girl of non-consanguineous parents. What is positive about the history, she has no siblings, and there is a maternal first-grade female cousin on the mother's side who died due to aplastic bone marrow at the age of 12 years. It was a very severe aplastic bone marrow anemia. And in personal history, it was very important to notice that she had intrauterine growth retardation, and she was born only at 7 months of gestational age with a weight of 1,720 grams. And this was because she was losing weight, and they decided to bring her. Well, what's the current disease with this patient? Well, she has got recurrent episodes of severe thrombocytopenia up to less than 1,000 platelets, neutropenia up to less than 100 neutrophils, and anemia up to less than 6 grams. And this anemia was with low reticulocyte counts, around less than 1.5%. In total, she's got 12 episodes The frequency of these is every 3 to 21 months of these episodes. And well, down here in the lines, you can note at the time which these episodes presented. The first one was at the age of 11 months. And these episodes lasted for the minimum 21 days and the most longest episodes 2 months. And they truly resolved spontaneously aside from the transfusions. It is worth it to note that nearly the two last episodes, episode number 10, it was only presented with thrombocytopenia, and episode number 11 only with neutropenia. And it is worth it to note also that some episodes were with lymphopenia, around 1,000 lymphocytes. Well, it is in these episodes, everything began with a high fever. It was the first thing that the parents noticed. And then different symptoms appeared, not always in the same order, but they were always vomiting, hyporexia, diarrhea, petechia, mucosal bleeding. I suppose is associated to the very severe thrombocytopenia. This is very important characteristic: total alopecia, pneumonia, oral candidiasis, and there was an erythrocyte sedimentation rate which was elevated around 40. And despite all these characteristics, is now unmuted. And despite all these characteristics, the patient did not appear like severely ill. It is worth it to note that there were no lymphadenopathies or no hepatosplenomegaly. Sorry, is the audio okay? Well, okay, thank you. So it's important to notice that there were no lymphadenopathies and no hepatosplenomegaly. And this patient really didn't seem to respond to anything that we gave her, like GCSF or IVIG. And the father noticed that there was a shorter duration of one episode at the age of 8 years with a high dose of systemic corticosteroids. And it's also worthy to note that between these episodes, that were 12, but this patient just had like high respiratory tract infections, mild with purulent discharge. No hospitalization was needed. She never had severe or opportunistic infections. And it's very important to notice that her hair grows completely back again. And between these episodes, we found a normal CBC. No, sorry, I'm reading a questions about tonsils. I didn't check on that. So let's see. And while there were other clinical features that presented also with these patients, she had mental and psychomotor retardations. She walked at the age of 4 with a speech delay, also around the age of 4 or 5 years of age. She began eating and dressing by herself at the age of 9. And there's a growth retardation. She is actually, she weighs 18 kilos and she's 1.14 meters high. Both are less than P3 for her age. She also has microcephaly, and this was noticed since birth. She has ataxia. She really has a difficulty with the left side a little bit that has been improving throughout the years, especially since she turned like 6 or 7 years of age. Mild left hemiparesis, and important to notice that right now she has no secondary sexual characteristics at all. She has never presented aggressiveness or seizures around her life. And her current neurological and physical development, she's now nearly 12, and it corresponds to a 6-year-old. The next slide, I think, is the pictures of the girl, which I wanted to share with you. This is when she was born before at the age of 6 months, before any episodes, and she has like a normal facies. She was a healthy child. This was at the 8 months when she was beginning to crawl. Everything seemed normal up to that day. And then you can see the first episode, 11 months, completely loses her hair. At the age of 4, as you can see, her hair is thick and is abundant. And she has here a little bit of the ataxia. I was kind of mentioning it. I don't know if the photo shows it as good as I would have liked. At the age of 4, another episode, again, complete alopecia, but only of the hair. The eyebrows were always present. And then at 5 years of age, her hair also grows completely back again. It's a thick hair. And this is a picture we have just taken of the patient 2 or 3 days ago. That what you can see here shows stature, and well, her face is kinds of look normal. Her hair is abundant, long, very thick, no? And as you can notice, well, we examined her no secondary sexual characteristics. Well, her CBC, these we have between different episodes, no? And you can see that the platelets really go down up to 4,000, hemoglobin up to 7.2 or 6.8, white blood cells as low as 1,000, neutrophils sometimes being absent, lymphs in some occasions very, very low, like 960. We performed some immunological testing. These were done in our hospital during an episode. You could see that immunoglobulins totally normal, and between episodes, immunoglobulins were also normal. And then we did lymphocyte population, the basic one that we have on the hospital. And as you can see, CD3 cells, CD4, CD8, CD19, and CD56 all look between the ranges for her age. And this is more studies that we could realize thanks to Germany, to this institute that helped us with this patient. And I want to thank them for this. And as you can see, there is nothing really remarkable that you could really check on it. CD3, CD4, CD8, CD19, 56, all between the normal ranges. This study was done May 2014. We did also a B lymphocyte subpopulation assay that also was normal, CD19, 27 positive cells indicating memory cells, all normal, and switch B cells also normal. And we also did a T lymphocyte subpopulation and an extended assay showing naive T helper cells, memory T helper cells, the gamma delta double negatives, the alpha beta double negatives, and the resynthetemic immigrants. And as you can see, all within ranges. Extra testing that we realized, infectious disease testing, everything was negative, at least for EBV, CMV, parvovirus, herpes simplex, toxoplasma, salmonella, brucella, also viral hepatitis and syphilis testing. We also did some genetic and metabolic testing, and it was really unremarkable. You could see within normal ranges. We checked for urinary abnormal metabolites, none. Amino acid chromatography, normal. We even did some tested newborn screening tests for hypothyroidism and phenylketonuria, normal. The karyotype showed normal, girl. And DEB test, what look autosomal breakages, also normal. Regarding pathological testing, to discard some pathologies in this sphere, the red lymphocyte count, as I have mentioned, it was low, haptoglobin within ranges, LDH a bit high, serum iron a bit high, transferrin a bit low, ferritin it was very increased. And we realized some bone marrow studies. You can see here some examples during an episode and between episodes, and they were really both normal. During the episode where we could notice hypoplasia, but there were no hemophagocytes noticed. And between the episodes, we had several testing with a reactive bone marrow. And we also did some panels of autoimmunity, which it was also negative. Sorry, it doesn't show. And in the imaging testing, the only thing that really was kind of remarkable was a global retardation of myelinization, but nothing specific on the cerebellum that we were kind of expecting. So this is the problems, just a summary, so then we can discuss a little bit. We have recurrent severe pancytopenia, recurrent fever, recurrent sinus infection with pneumonia and candida, mental and physical retardation with microcephaly and ataxia. So I don't know what you think about it.
Okay. Thank you, Gisela. So we do have a very interesting patient with intermittent pancytopenia and intermittent or persistent febrile episodes with some constitutional findings with microcephaly.
Your line is now unmuted.
With microcephaly ataxia. So
I think.
I was just wondering what would be the audience response for a patient with suspected immune deficiency, intermittent pancytopenia, and with persistent markers of inflammation and fever.
Does anybody think that it might be a periodic fever syndrome? It can be a periodic fever.
Well, it's periodic. It's okay, but it is something periodic, and there's fever in it. But this type of clinical phenotype does not make really sense. And if something doesn't make sense, I come from the old thinking, could it be something of a environmental effect? And we called it, in the old days, we called it Munchausen syndrome. In English, it's called Munchausen, but Monsieur Munchausen pronounced his name Munchausen. That would be something that's being created from the environment. It could be involuntary or voluntary by somebody who is close to the patient.
The possibilities with this case we have also been thinking is, can this be an autoinflammatory syndrome like NLRC4, where there are recurrent macrophage activation-like presentations that are known to happen in these patients? And the other possibility, we don't know based on the bone marrow if there is any evidence of hemophagocytosis or not. There are hemophagocytic lymphohistiocytic disorders that can present with intermittent fever, pancytopenia, but some of them are self-limiting, like XTX11. So I don't know what Kate or Hans thinks about these differentials.
Well, it's a good story for HLH, right? You don't really have enough information to be sure you meet the criteria. And I think, Gisela, you said that there were no hemophagocytes on the bone marrow, right?
No, that we detected.
And so one important thing to remember that I think Shan was trying to get at is you don't have to have hemophagocytes to make the diagnosis, right? They're hard to find. They can come on later. So you don't have to have them, but they're certainly very reassuring. So the things that would argue for HLH that are part of the diagnostic criteria are the pancytopenia, the fever, and the elevated ferritin. We don't know about triglycerides. Usually you will see a discordance between the CRP, which should be high, and Gisela told us that the CRP was high. But paradoxically, the SED rate will usually be low in HLH, and we didn't hear about that. So we don't quite have enough information, but it does have that flavor, right? But it's hard to put together with the microcephaly and the IUGR. There is an inherited metabolic disorder called lysonuric protein intolerance that is associated with poor growth, and it can have an episodic HLH-like flavor to it. This is not a great story for lysonuric protein intolerance. Usually there's a pulmonary component as well, but it would at least be something to put on your differential, I think.
Right. For us, it was very positive that the pancytopenia was very recurrent and not becoming like every single time worse, and the complete alopecia that we didn't didn't know where to fit it.
It's definitely a strange combination that is hard. It's hard for me to come up with a single unifying diagnosis. I don't know, Hans, do you have any words of wisdom?
Well, I still think this, for instance, this would resemble a irradiation sickness. You get all your bone, and it would not be lethal, but sublethal. You would lose your hair. You would your bone marrow would become aplastic. You probably would get some of the other symptoms and signs that she had, and then you could recover. I'm not sure if this is a genetic disease. I'm not saying that it is not a genetic disease, but I'm worried about here of something that is environmental. It's just so unusual to explain this by a single gene or maybe a few genes that could be abnormal. It would be certainly worthwhile to look whole exome sequencing if there is something that comes out.
So one thing that I think Cecilia did not find, she had it in the presentation, is this kid also had onycholysis. I think with that and also hair loss, we have seen some patients with Kawasaki have this nail bed loss. I don't know if it's part of a hyperinflammatory syndrome that you have, like a telogen effect that Mike Goodman has pointed out. So I'm not sure it's a real autoimmune phenomenon leading to hair loss, but if it is more like telogen effluvium and hyperinflammation associated, like onycholysis that you see in Kawasaki disease, these are very stigmata for something inflammation going on. So I'm not sure how to put in all this in the context of Machu-Horton syndromes by proxy or by herself.
Well, we still have got the last slide of the problems we were considering about DNA recombination defects, DNA repair defects, including breakage syndromes or congenital medial failure, which Dr. Kate Sullivan suggested once we talked with her about this keratosis congenital, but the syndrome with the most severe spectrum, Hoyer-Heidarson. I hope I pronounced it okay. And in November 2015, last year, and I want to thank Texas Children's Hospital, Dr. Jordan Orange, for his support, they did whole exome sequencing, and the report was that there was no obvious genetic explanation. They also did, as they were not finding any problems, a microarray analysis, and they find 2 areas of duplication on chromosome 14 and on chromosome X. And they are not sure about what to do with these areas yet. Some of them, especially in chromosome 14, there has been some breakage syndromes, like Nijmegen, related to it, but this is something that we are just beginning to study. I'm seeing a question about telomere length. Unfortunately, we don't do these tests back home, and we haven't been able to concrete any help yet for that, but it will be very, very interesting to fulfill it. So this is the end of my presentation. Thank you so much. I don't know if you have any extra comments or questions.
Gisela, are the duplications, is there a chance that the breakpoints are interrupting the gene? Did you look at the endpoints of the duplication?
We just received the report. We are just waiting to have more information about it. It was just like a little forehead, like a little notice. So I'm not very sure about that, the study itself.
Did you look at the parents if they have similar duplications?
No, not yet. That is our next step also. It was also suggested.
Yeah. That would give you an indication. If one of the parents has both of these duplications, then it's not causative. If one would come from the father, one from the mother, it would also suggest that this could be causative if you have both. Or if it's a new event, that also would suggest that maybe it's causing some of the problems. So it's I think it would be interesting to know if there is a genetic complications in that family.
Right. Yeah, that's definitely one of our next steps.
Right.
The audience has suggested testing telomeres for her, so I think that will be consistent with working up for keratosis congenita and that spectrum of disorders.
Okay. Sounds good.
Kate, do you have any specific comments? Because I think you are published on immune deficiency associated with dyskeratosis congenita and telomere defects, right? So
I really thought this was going to be DKC when Gazella first posted it on the CIS listserv, but the genes are all known, and the whole exome would certainly argue against it.
Okay. And we do see subtle immune deficiencies in DKC, but in this patient, it's pretty much the immune profile is very unremarkable. And we don't see this intermittent severe pancytopenia. They're typically progressive, right? So that makes it even more, what are these episodic disorders? And the bone marrow rebounds so robustly with normal counts. Of the DKC patients I have followed, none of them behave like that. So.
Right. I think I could imagine that the pancytopenia would wax and wane, but it wouldn't account for the fever, and they sound much more explosive than what you get with dyskeratosis congenita.
Okay. Thank you, everyone. So this has been amazing 2 presentations, and I would like to thank the presenters and the mentors for the valuable inputs. And we will look forward to the next presentation by 3rd week of Feb. We will get back to you with the specific dates. And if you have any specific comments about this, please do let us know. Thank you.
Good night, everyone.
Good night.
Good night.
Good night. Thank you.